Hi, I'm Monty Mythen, Editor-in-Chief of Top Med Talk, coming to you live from Anaesthesiology 2018, the annual congress of the ASA, the American Society of Anaesthesiology. I'm sitting here with Desiree Chappell, the Associate Editor of Top Med Talk and the US lead. Desiree,
hello,
welcome
Monty.
Back. How many of these have we done now?
A couple.
We're at the Smith's Medical Booth 1519 at the ASA in this wonderful trade exhibition, which I keep getting wrong, which is now called
Connection Center.
And we have been joined by a very special guest, old friend Stuart Grant. Stuart, how are you?
Great to see you again, Monty. Desiree.
Great to have you back. So, Stuart, you're Professor of... And I'm going to say you're a Professor of Anaesthesia, but you're a Professor of Anaesthesiology, is that right?
Yeah, we better get the American pronunciation right. We are in the United States now.
At Duke University Medical Center in North Carolina in the USA.
And I'm picking up a southern accent pretty well, I think.
Or Glasgow.
Yeah, south of Glasgow, yes.
and you're originally from Scotland?
Yes, trained in Glasgow.
And you went over to Duke how long ago?
1999, went for 1 year. I actually went to... They're opening up an ambulatory surgery centre in Glasgow. Standalone centre, and they're doing it at Duke. And I thought, well, if I spend a year there, see what the problems are, then come back to Glasgow and be part of that process. That never really panned out. Yes.
So
well, they said, my wife and I said, I will stay for 3 years, then at 5, and now I've worked in the United States longer than I was in the UK now. Yeah.
And the kids are born there, grown up there. So you
2 girls born in Glasgow, and the third one, only one was the one that looks most Scottish with the red hair is the actual only true American.
But they're fully integrated into North Carolina now.
They don't sound like Dad. Yes,
okay.
They don't.
And they understand the funny sports, do they?
One of them...
The funny sport.
Yeah,
really?
They play football with a pointy ball and that sort of thing.
Yeah, well, one of them played...
you're in the US, right? Sitting here.
So one of them played field hockey, so a real European sport. She played field hockey, so...
So running around with the ball on the ground with a stick.
Yeah, you'd play hockey, yeah.
You do, the Brits understand that.
So that was her... she played it, did the college athlete thing, which was really amazing. Nike Christmas every year. Amazing.
So, Stuart, anaesthesia to enable ambulatory surgery, I think, has been a big part of your life. A fantastic service at Duke, as has pain relief and particularly the use of regional techniques.
Yeah.
Correct?
And before avoiding opioids was sexy, I would call us the original Hans recovery, otherwise known as regional anaesthesia.
So, if you put a proper block in, you could just go home straight away anyway.
There's so many variables. But yes, what really made... You remember the basket of cases in the UK was a limited number of day surgery cases. What really made day surgery spread, I think, was propofol, one, and also the use of regional anaesthesia as facilitated ambulatory surgery, particularly for orthopaedics. It gets a bit more complex now. We're changing to more robotic and laparoscopic surgeries, and it's been a really interesting area, the growth in these new blocks that are coming out for particularly abdominal surgery.
Because as the audience gathers here, some people thinking, what language is that person talking? but it's English, isn't it, Stuart?
It is, good basically.
I wanted to ask you what's new, basically.
Yeah.
I know you've got some posters here. You're always doing new late-breaking stuff. What's new at this ASA from your perspective that you've brought to it?
For me, I brought along a medical student who did a lot of work for me looking at, for nearly 15 years, we have used paravertebral nerve blocks in breast cancer surgery. Initially to reduce nausea and immediate pain, but also been some great data from other centres looking at theirs and looking at really important outcomes. Does the anaesthetic make a difference in breast cancer recurrence or even mortality? Our data is only retrospective, so there's always that caveat. But we
pause for 1 second, Stuart, because we know we have listeners around the world, and not everyone's in this space. So, breast cancer surgery is the area. The paravertebral nerve block.
Yeah.
Just talk us through where the needles go and what the expectations are.
So, originally we're doing it blind, and we're placing the needle in the patient's back, just off the midline, underneath the rib, making sure we don't go too far and get near the pleura and the lung. Now with ultrasound we can be pretty accurate where we're placing that, but we're trying to numb up the patient's chest wall.
The chest wall. And are you putting a single shot in there, or do you put catheters in
Mainly single shots, unless somebody is a high opioid tolerant patient, high opioid use intolerant, or particularly anxious or depressed, or some other that make them think there'd be much higher pain than normal.
And the pain, well, from what I've seen, it's not my specialist area, but the pain relief when they're done well, particularly in the days of ultrasound guided, is excellent.
Yes, and we'll use that as the anaesthetic along with some propofol sedation.
But the real big question, which I think you're going to tell us about, is does it make a difference to the outcomes from cancer?
And we know it makes a difference long-term chronic pain, 3 to 6 months reduction in chronic pain. And we basically have got a mixture of providers of different skills at Duke. So some people will do a volatile anaesthetic with opioid, and we've got others that will use a paravertebral nerve block with propofol. And we've got a significant reduction in cancer recurrence and also 5-year mortality in patients that use a combination of propofol and paravertebral nerve block. Now, is it the propofol?
Yeah.
Is it the paravertebral nerve block? Is it avoiding the opioid? Is it avoiding the volatile?
Is it patient selection? Is it surgeon subtype?
So we've looked through the multivariate analysis. It doesn't vary by surgeon. We've broken down all the different that we could do, looking at the receptors, positive, negative for hormone resensitivity, and looking at major morbidity. Doesn't seem to make a big difference in cancer recurrence, but our ASA status is the same between the groups. And interestingly, in those that are lymph node negative, and remember we only sample lymph nodes, but I thought if your lymph nodes are already got the tumour, I can't maybe make a difference in the recurrence. It's already spread. So we looked at the subgroup that are lymph node negative, and the difference was even more pronounced.
Oh, wow.
So I don't know if it's a propofol effect or it's avoiding the volatile anaesthetic, but there's some really good science to back up this, that animal work and all, looking at the effects of propofol in metastasis as well as avoiding volatiles, and looking at natural killer cell function and our ability to fight tumour growth and spread.
Is it actually opioid free? I mean,
So patients will end up getting a little bit of fentanyl when the block is paced, maybe 25, 50 mics, and they're given post-op. They're given hopefully a multimodal regime and with some opioid as well. Again, what tips the balance to show this difference in outcome? This is going to be interesting going forward, and I know there's actually 2 large prospective trials looking at this. I don't know if they use propofol. I don't know if it's volatile and paravertebral blocks, and we'll be interested to see. It's going to be a really interesting space in the next few years.
How many patients and what magnitude of difference?
We've got just over 1,000.
Okay.
Yeah, and we're talking like a 20% reduction. You look at the odds ratio, so that's 15 to 20%. That's pretty significant.
So the anaesthetic clearly might make a difference, and you've already alluded to that data. But is there any? So the gases, are they different between the TIVA group and the volatile group?
Are they?
Particularly, so the inhaled gases, particularly oxygen.
So we're getting usually supplementary oxygen through a face mask, so it's guessed the FiO2 and it could be anything really difficult to measure, but we're usually given like a 30-40% if you see exhaled oxygen content. So that's our usual clinical practice. So that's not really different from the concentration that you'd be getting as your...
Well, what are they getting if they're getting a volatile?
If they're getting a volatile, it's usually like 30 to 40% of oxygen.
You're driving, you think... Go on, Mike. Tell us.
Just looking at the long-term outcome from the proxy study, it's a post-hoc analysis, but the more oxygen versus less oxygen, which was all targeted originally against the wound infection story, did suggest that hyperoxia was associated with a higher degree of cancer recurrence and mortality.
Mm-hmm. So it was 80% there, wasn't it?
It was 80.
That was a very high percentage.
It was.
But it'd be worth looking back at that. But they wouldn't be giving them 80%.
So they're not. They're usually getting nasal cannula, supplemented oxygen, or a face mask with 5 to 10 litres. So there's nowhere near 80% oxygen in the And for the actual control group, that are either an LMA and a volatile, they're usually running about 35-40% as a concentration.
They don't give them 100% before they take them out at the end?
For a minute or two. So
how long does it take to cause harm?
How long does it take to cause?
We don't know. We're looking at the moment. We don't know. But they typically are, when we actually go and look, it's rare for people to give less than 50%, and quite often more than 50%.
Yeah.
But
yeah, we're generally looking at oxygen-rich air, and our machines are usually about 35-40%. That's where we normally set it.
So, and you said there are some big trials.
Yeah, Donald Buggy has just completed enrolment, I do believe. I don't know any data on that perspective. What I'm not sure if his groups, if one of them was propofol. This is where it's all teasing out. I don't know if it's all volatile plus PVB, and I wonder if that. I'm desperately waiting to see his results.
But there's a couple of groups looking at the straightforward question of volatile versus propofol. One I'm focusing on cancer surgery.
One from London, I thought they were looking
and there's
at
an Australian group.
Australian group as well, yeah. Uh-huh.
So fantastic, well done. A medical student did that with you, is that right?
He did the Scott work, the heavy lifting. He's currently Matthew Lies. He's looking for an anaesthesiology residency. Fantastic chap. Let's put a plug in for Matt, who did all the work.
Get Matt over here to talk
about
it.
really. He needs to come and talk to us.
Yeah,
gets in town today.
Good talker.
Yes, he's a great guy, great kid. Amazing job he's done.
Oh, brilliant. So what else is news? You said there's some other.
So looking at recovery, one of the things we've instituted, which has been an interesting topic, it's not a required monitor, but using objective monitoring and neuromuscular blockade. So we're using EMG monitoring, and we went through the process of getting that available in every OR, and then educating staff. And somebody did this before in Iowa, and the chairman said, you must use it. I don't have that sway, Duke, even though I think I'm very important. So we've tried to encourage people and bring it along rather than tell them what to do. And we ended up, like any new adoption technology, you've got your pioneers and then your laggards. So we've got about 60% are using the EMG. And we as a prospective cohort, 900 patients, measured paralysis and arrival and recovery, and found that the EMG, the objective monitoring neuromuscular blockade, reduced residual paralysis. The only reintubations we had were in our laggards, or 40% to carry on with the subjective monitoring. And we've also just looked long-term, looked at either a chest infection or chest x-ray, and went through chart by chart and showed a reduction in chest infections and pneumonias in the patients that use objective monitoring and neuromuscular blockade.
So this is, for people who are non-specialists in this area, you're putting a monitor on of some form. Do you use this sort of thing in the crook of your hand or somewhere? Or
we actually use EKG and actually measure percutaneously with EKG electrodes the EMG.
Of it, on the fingers, on the hand, or wherever you do it?
Yeah, put it on the hand.
And then you're twitching in some way, and you're saying, well, actually, they're paralysed or fully recovered their muscular function.
Yeah.
And many patients, if not monitored, are delivered to the recovery area still partially paralysed. Is that right?
Yeah.
Well, shame on us. I mean, that doesn't sound good, does it?
It's interesting because if we all get together, we can all agree that patient safety is a priority.
Yeah.
We all think we give a great anaesthetic, and then when we carefully look at it, it is very interesting. One of the most startling cases is one where we put the monitor on recovery, and one of the patients was lying peacefully. That's what the team thought. But then put the monitor on, and we saw there was quite a degree of residual paralysis. We then gave some Sugamidex reversal, and this patient became very animated. So the ideal patient from our PACU nurse point of view, lying there peaceful, looked perfectly serene, but turned out they're actually very, still was quite paralysed.
Why isn't this sort of thing mandatory?
So the Association Anaesthetists just came out with new monitoring guidelines, and they said, really, we think strongly recommend you should, but it's not mandatory. The associations in GB and Ireland.
No, I was just going to say, in practice, I think it's sometimes hard to get people to change. Did you have you shown the data to the laggards? What do they have to say about their outcomes?
So if you have an interaction where a patient gets reintubated, I looked through data that have been looked through our pharmacists at reintubations in PACU, and it's interesting. Patients were assumed often to have opioid overdoses, and they'd be given naloxone, and they still wouldn't waken up, and they still made the diagnosis of opioid overdose. Now, I've never had naloxone not work, but it's interesting how people come to, different conclusions. Why were these patients not doing well in recovery? So
yeah, have you changed practice as well with how you reverse patients using different medications?
Yes, but I think no matter which one, I realise using the monitor how slow neostigmine is.
Right.
And my practice has changed now that we're doing so much more laparoscopic work, and we're done.
Yeah.
And we've got to hit the PACU. That it sometimes takes 50 minutes to an hour for neostigmine to work.
Wow.
And
really?
Yes.
Wow.
And the number of times where it fails to work is remarkable as well, the variability in that recovery. A large study done in Canada, the RECITE study, the instance of residual paralysis was large. It turned out that we did this look after education, after we put the monitors in, we had a much lower percentage, but still there is a...
Yeah.
So what are you going to do about that at Duke then?
Educate, re-educate, educate, re-educate.
Is it time to get tougher than that? I mean, you seem to be reporting live stream that at Duke you have patients who are residually paralysed with objective evidence of that who have a worse outcome. Isn't it time to man up?
And we've got a lot less than probably we have in other institutions that are not doing this.
Exactly. I'm saying it's,
So we all need to...
I mean...
one of the difficult things is, if we make short of what we do is big syringe, little syringe, tube. I'm telling people that 1/3 of their practice, one of the core, they're not doing right. That's a very difficult conversation to have with colleagues, and it hasn't gone very well all the time when you suggest this. It's really, human nature's interesting.
That's strange in our profession, isn't it? I mean, we get on those aeroplanes, and if they said, "Nah, we only crash 1 in 3." It's not. It'll be fine. You've got most of the planes are okay.
Yeah.
No. Okay. Right.
Yes.
So,
I don't. Where does it come from? Where does it? How do we get that conversation going? I mean, we surely can. We have plenty of difficult conversations every day with our other non-anesthesia colleagues.
The IRS came out with guidelines last year on reversal, and part of them were that you should use objective monitoring. Part of it is the devices are not entirely reliable.
Oh, okay.
I think also that if you actually look for those events that change our mind, those two true catastrophic events, reintubation actually occurs quite rarely, maybe only once every 1 or 2 years if you're doing a good job.
Yeah.
And that's, the events that don't occur as frequently, it's sometimes more difficult to change practice. And as I say, patients look quite serene when they're lying there.
Well, and there's a big difference between totally awake, jumping up and down, once they've been fully reversed, to complete re-intubation, that there probably are some issues going on in between.
Yeah, but some degree of persistent pulmonary dysfunction is common, relatively common. Chest infections are relatively common.
Yeah.
Do you think...
and we do know that neuromuscular blocking agent and muscle relaxants are associated with a higher mortality and anaesthesia. A lovely big study published doing data from Boston. That
increasing evidence about these post-operative troponin rises as well. I can imagine if you're lying in recovery part paralysed, that's pretty stressful.
Yes.
As well. Interesting. Lots of more work to be done. So we've got a question come in on Slido. To remind people, you can go to slido.com, put in the code TMT ASA 18. We've got a question that's come in here. Can you send knee surgery patients home on day of surgery? How do you manage pain?
So, yes, you can, but I think picking the patient is important. And the question is, should you? Because if you actually look at the timing of some of the complications, and then what support do you have for these patients? Are they going to carry on doing their physical therapy?
Yeah.
So there's a whole host of systems issues that need to be put in place rather than just, wave goodbye and kick them into the Cadillac.
So in selecting the patients, is it that you select the patients, or there are a subset of patients who come to you and say, I really want to go home as quickly as possible? I really want to go home.
Yeah, we always say first prize at Duke is 1 meal, second prize at Duke is 2 meals. So I think getting out of hospital with a high incidence on nosocomial infections, potential for drug errors. There's some people want to get out as soon as they can. And you know, recuperating at home is much better than recuperating in a hospital. And so, yes, we have got those patients. And the surgeons will suggest that some people latch on straight away. And the surgeons use their discretion about, you know, who they think is reasonable. And they obviously know the patients much better than we do. They've usually had a couple of visits where the initial problem, then they'll discuss the option of surgery, and then there's, okay, what's this going to entail?
And any bad news?
Any bad news about going home?
Yeah, I mean, because it sounds a bit scary for people who aren't used to letting people go home straight away with their knee replacement. But it's a knee replacement.
Yeah.
You know.
And I suppose when we were 15 years ago, we were sending people home in day 2. That was scary to people who were keeping them in a week.
Yeah.
And I think this is just part of the of that progress.
And are you doing day case now or 23-hour stay?
So
do you have a night?
We actually, they come in and they actually get 2 sessions of physical therapy before we let them go home.
But can that be before the sun sets?
And that's usually going home. That's usually a lot less than 23. It's usually they come in for their surgery, we do the surgery at 7:30 in the morning, and they'll go home at 5-6 p.m. that day. So it's a working day.
Get their Starbucks on the way home.
Readmission rates higher, or
No.
But patient selection is the
and
key.
That's
So the second part of the question is how do you manage the pain then? What are the secret? What's the secret sauce or sources?
So, talking about it, you will have pain. Don't say pain-free. So number one, and then using your basic multimodal techniques and making sure people take those medications. We give them orally in pre-ops, acetaminophen and anti-inflammatory. And then we use a spinal anaesthetic, depending on the speed of the surgeon. Whether there's a trainee involved, it might be bupivacaine versus something like bupivacaine for some of our slower colleagues. And then we place an adductor canal catheter, and we use infiltration around the knee with some local as well, I think called the IPAC block. We infiltrate that posterior part of the knee. And that allows them to hyperextend and stretch out that knee, the IPAC does. And the adductor canal allows them to ambulate safely. And there's a trade-off here. I think a femoral nerve catheter is going to give you better quality analgesia, but I can more reliably ambulate with people who get an adductor canal catheter.
So you leave the catheter, they go home with
with a disposable pump.
Yeah.
We give them a call daily. They've got a number to call us should be any issues. And part of that is patient selection, not everybody, but they can call us and call our pain service.
Do you get any institutional pushback for that? Because, I mean, isn't that bad for business? Doesn't the hospital get paid for people being in it, or in the US system?
Medicaid used to, cut your reimbursement if you send patients home sooner.
Too early.
Too early. Yeah, you would do it. The patient was in parts, but the depends on your insurance provider. So,
and they're doing more bundled care options now with total joints.
Yes.
So that has changed.
And the US government has actually said like a unicompartmental knee should be an ambulatory procedure. So they've actually changed the reimbursement. So actually now it's a unicompartmental knee. That really is a day case.
Because day case hips for selected patients is relatively common now.
Yes.
Yeah.
It's the day case knees. But double knees?
That's what I was just going to ask too. Do you do double knees?
We do double knees very rarely. There's sort of like fair criteria for that. You've got to be fairly fit and healthy patients. And we'll put in 2 adductor canal catheters for those. Yeah. Send them home with the double pump.
A question I get a lot about the adductor canal blocks is, people are concerned that there's, I guess, a bit of a learning curve when it comes to putting those in. How is that something that you guys worked out between providers?
Yeah, so we've got a good regional group, and when we started doing them, we had to figure out exactly where we're going, and there's first the ultrasound imaging, and then exactly where do you leave the catheter and how far up or down the leg do you put it, and again we'd actually go in together, find out what works, follow the patients up inpatient, and then transition to the outpatient setting when we're comfortable and happy. But if we do know you're going home, I don't want to put a large bolus in and then find out later the catheter's not working. I'd rather put a lower concentration, lower volume, even short-acting local anaesthetic, so I know the catheter is in the right place. And I actually do the catheter in recovery. When I put the thigh tourniquet on, I find there's an awful lot of movement of the catheter. So I actually place... The workflow isn't ideal, and it's, get one patient in the ward, then go back to recovery, and put the catheter, and the patient 1 is in recovery and patient 2 is already in. We'll put the duct canal catheter on recovery when under cover of the spinal that's resolving.
Yeah, that's all common things
Busy
that
day.
we hear a lot. Yeah.
Busy day. Well, Stuart, you've been very generous with your time again. Any other updates? Any news for us? Anything at all?
No, not particularly. I think of.
What do you make of Brexit?
So I'm now. I wasn't allowed to vote. I didn't get an opinion on that. When I make a Brexit, I think it's crazy, but I didn't get a chance to vote in Brexit.
Do you think it'll happen?
I didn't get a chance to vote in Scottish independence either. So I was watching from afar.
Do you think it'll happen, or do you think it'll all fall over at the last minute?
I really don't know. It just looks so disorganised. It's amazing UK politics from afar. It's my family were split. I don't know what yours are like. Do you have people who voted for and against it?
No, not really.
Yeah,
I do know of people who have split families, but ours is pretty solid.
Yeah, solidly out or in?
Solidly in. But we're living in the London bubble. We kind of thought, just went to bed, no problem.
Yeah, the vote was similar. Like Scotland and London seem to be this.
Exactly. The rest of the country was,
Yes.
Anyway, we'll see what
I don't
happens.
think that's exclusive to the
UK. But there's even more exciting politics in the US.
Well, Stuart Grant from Duke University Medical Centre, thank you very much indeed.
Monty, great to chat.
Thank you, Stuart.
On your excellent work. And everyone, we'll be back soon here at Anaesthesiology 2018. People should follow us on social media, shouldn't they?
They should. We haven't talked about social media today, but please, Twitter, Facebook, LinkedIn, those are our big ones.
Yeah.
I think we even have a YouTube video up now, too.
That'd be embarrassing. And you should subscribe. Stuart, have you subscribed? Subscribe
to topmegtalk.com. You go there and subscribe.
You can see this here. You could take that home for the girls.
Do you know where this comes from?
That's
Marshall Amp from the UK.
Yeah, Jim Marshall from Hanwell, I think, originally, near Ealing.
I play the guitar badly. I've got a Fender amp. That's
keep
Marshall.
saying this was made in Canada and designed in Scandinavia or something. But there he is, Jim's. It's a good old weight now. I feel that.
It's good. It's going to last, and it looks really awesome. And sounds even
better. Phone the girls up and tell them to subscribe.
Dad's won.
No, you haven't won yet.
No, haven't won.
Drive subscribers, and you might stand a chance. Stuart Grant, great to talk to you. Thank you very much.
Thank you,
We'll be back soon.
All right.
Top Med Talk.